So you just start the recording as usual. We're quite comfortable with hybrid meetings nowadays, so I'll not go through all the usual protocols of it. I think everyone understands the concept of putting your hand up, whether it's a real one or a yellow one. We're happy with that. So we have a couple of apologies this morning, Mark. Do you want to pick those up?
The only one that's been intimated to me is John Nixon. I don't know if there are any others from within the room.
Yeah, we've had late apologies from Willie Payton, the carers rep. Thanks.
So we'll note those apologies. I know that a number of people are unwell at the moment, so hopefully no one's succumbed to any lurgy. In terms of any declarations of interest or any transparency statements, does anyone have any statement that I have to make this morning? See shakes of head in the room, and I don't see any hands up, so we'll take that as no declarations of interest. Okay, thank you. So that takes us on to item 1 on the agenda, which is the membership update. We've got a few updates this morning, so Mark, I'll hand over to you on this.
Thank you. Yes, the paper sets out the changes. If you just bear with me 1 second. So Unison have advised that John Nixon has replaced Amanda Walton as a non-voting member in the IGB, and that was with effect from the 16th of September. The HSCP has advised that Lucy Dornan has replaced Leslie Nish as the Health Board staff member. And in respect of the Health Board voting members, we've been advised that Colin Neal retired on 31st October and that Becky Metcalfe has replaced Colin as a voting member. And over and above that, the Health Board have further advised that Dr. Shilpa, and I can never say this, Shabab Prasad has been reappointed to the non-voting position of the other medical practitioners with effect from 17th January. And again, that appointment will be for a period of 3 years. And the Dr. Stuart Sutton has been reappointed to the non-voting position of general practitioner in the IGB with effect from 19th January. And I will apologise again to Shilpa.
Thanks for that, Mark. So I know we don't have John with us this morning, but welcome, Lucy. Good to have you on board. Likewise with Becky, and obviously great to have Stuart and Shilpa continuing. So continue. It's great that we've actually got all these posts filled, because it can be a bit of a challenge to make sure that we get a full complement of representation. So thank you for that. That takes us to the next item, which is the minute of the previous meeting. I will pause to check if there are any comments or questions of factual accuracy. Otherwise, we'll take that as an approved minute. See any hands, so content to take that as an approved minute. Thank you. So item 3 in the agenda is slightly different for Renfrewshire IGB. It's something that when Billy and I came into roles as chair and chief officer, we talked about trying to bring to life, not only when we meet as a development session, when we meet privately, but actually in our public sessions, to talk more openly about what the partnership actually does and the role of the integration joint board. So we thought it would be good to start introducing a bit more real life examples of what takes place. So I'll hand over to you, Billy, to introduce it properly.
Yeah, thanks, Margaret. As Margaret says, our intention is that we'll bring one of these stories forward to each of the IJBs, and again, hopefully what it'll help connect us with is the work of the partnership, and in particular start to give some examples of where we're moving into that prevention, early intervention and different ways of working space. So this is our first example. It's from 6 weeks to Wellbeing, and 6 weeks to Wellbeing came about after a discussion between the Health and Social Care Partnership and OneRen colleagues about working together to address social prescribing, improving wellbeing and connecting into community-based activities. So with that programme, people can self-refer or be referred into the programme with sessions covering things like being active, arts, mindfulness, photography, heritage and games. The 5 Ways to Wellbeing is used as a guide for weekly activities. So being active, being connected, keeping learning, giving and taking notice. So those are the themes within the programme. During each programme, staff get to know individuals, work with them at an individual level and get to understand their interests, and then using that map to find then community-based activities that they can then attend in the longer term. So really connecting them into a space and a community that is meaningful and personal to them. The first programme was in Linwood Library, followed by Foxbar Community Centre, and the example that we're about to hear includes Susan and Maxine, who both attended the Foxbar Community Centre, and the 6 Weeks to Wellbeing programme is currently being delivered in Johnston Town Hall. So we don't know if we can run the video.
Hi, I'm Maxine. Mrs.
Hi, I'm Susan.
We met many years ago, but we were also, Susan moved back to the UK recently, and we were looking for somewhere to go to meet different people for different reasons. And I was at a place called the Chatty Cafe, and I heard about the wellbeing, and we started going to the wellbeing for the 6 weeks challenge, and we actually had a really good time.
I was dragged along to the Chatty Cafe by Maxine. She needed some company, and Charlotta put us onto the 6 Weeks to Wellbeing, and it was really good fun. I wish actually it could have been longer than 6 weeks. First week was just an introduction of everybody who was there, saying who we were, where we're from, that kind of thing, and then we did chair yoga, we did arts and crafts, we did games.
We went for a walk.
Yeah, we went for a walk around
Durrockstock
Dam, and just interacted with like-minded people, I suppose. It was just really, really, really great. Yeah.
Having now gone through the 6 week programme, I now feel more confident in myself. I have Parkinson's, and for me that's a big, big part of my life. And to be able to go somewhere and people don't know me and just get on with people and they just accept who I am, it's good. The girls, we decided at the end of it we didn't want to attend, so we still meet every second Tuesday now in the morning at the lagoon and have coffee and chat and see how everybody's getting on, and if they need something or need help with something, we all help each other.
And for me, I was in a bit of a rut. As Maxine said earlier, I came out from South Africa after living there for 51 years. Just packed up with the family and came over here. Didn't know anybody really apart from Maxine and her family, so it was great for me to get to meet other people. And I had a stroke in South Africa that wasn't treated properly, so that's sort of debilitating for me. And to have the help that the ladies who ran the course and the gentlemen who ran the course have put me in touch with different organisations that can help me, and it also got me out of a very big rut and sort of a period of depression as well. So I actually look forward to the socials and the getting to speak to everybody, even if we just chat on the WhatsApp group. It's nice.
Without these programmes, people would sit at home. We've got one lady that comes and she is literally becoming a recluse. And I'm trying to get her to go out and do different things, and even if it's just going to another group with me, myself, and she doesn't want to because she doesn't want to drive, it's coming into winter, I said I'll pick her up. And I think from that point of view, the social point of view, and people not being in the house and being able to talk freely if something's bothering them and they're worried about something, there's somebody they can go and ask for help and say, well, where can I go? And you can try and point them in the right direction on where to go for help.
Try it once. Give the first one a go. And then see how you feel.
No, give 2 a go.
Okay, give 2 a go, but see how you feel from there. It's like I say, I wish it could have gone on for longer than 6 weeks. It's great fun.
And it was nice because at the end what we did was we did a template of what we thought the next courses should be like and make them longer, what we would bring in. and we said, look, bring in books so that people can talk about books and say, oh, well, I went to see the movie, or I've done this, to get other people to go, well, I would like to go and see that, or I'd like to read that, and just to have a different talk in general about mental health, if you like, anything.
One of the things that they did when we did the first introduction was they pulled a paper out, or you pulled a paper out and it said there, what's your favourite movie or what's your favourite food? And it actually wasn't just us saying what our favourite movie or food was, it was got the whole table talking about and bringing up little snippets that they're probably buried somewhere in the back of their memory, but, you know, just bringing it up. And we all had a good giggle and a good laugh, and you know, it's just great. I think it's important that they carry on with these. There's a number of reasons. One, it's so like-minded people can get together, or maybe not so like-minded people can get together. It's good for mental health and well-being, and people who have possibly on borderline becoming recluses find something in there that's going to hold their interest to get out of the house and make an effort to come out to them. I think a lot of people will be sad if it stops, but certainly it will be to the detriment if it stops.
It mustn't stop.
No, mustn't stop at all.
Thanks very much for that, and thanks for the team. It was one of my requests to try and just bring to life some of the services that we have here in Renfrewshire. And I guess I'll take, not within this meeting, but I'll take feedback from members as to how this helps in terms of setting the tone of how we want to work together. I don't really want to take particular questions or particularly given we're talking particularly about two members of the public who've kindly shared their experience. We don't want to get into discussing them individually. But Lisa Marie, I see you've got your hand up. Do you have a general point? Because I don't want this to become a typical paper, as it were.
No, it's very much a general point, Mags, and so I suppose one where I have a particular interest as the chair of One Ren. First of all, thank you to yourself and Billy for bringing these things forward. I think it brings to life the work that we do. And actually, these are my favourite bits of our partnership working. Often they're the ones that are done quietly in the background that make a real difference to people's life, and they're quite soft touch interventions. And I think the testimony we heard from the ladies shows what a difference they can make, and I just wanted to highlight that.
Thanks, Lisa Marie. I think that's the sentiment that we're trying to get across. So we'll try and bring a range of different, call it patient or service user stories, but things that are happening here in Renfrewshire that might not typically make it into the formal papers that we're discussing, but really important work that we're doing. So, so thanks to everyone. Kath.
Thanks, Chair. I echo Lisa Marie's point, but also just to say this brings that mythical word of prevention and person-centred care into the room, and sometimes it can become a bit abstract, and this is bringing absolutely to life what it means for people. Thank you.
Mags, you're muted.
I am, thank you. I didn't say very much. All I was saying was I'm handing over to Billy as Chief Officer now, back to our usual agenda. Thanks, Jennifer.
Yeah, thanks, Margaret. So in terms of the Chief Officer's report, again, a full report, so I'll just touch on some of the highlights. The Belerno Centre in Bishopton, since we last met, has opened. So a fantastic example of a purpose-built and very modern health and care centre, and I'm looking forward to getting out and seeing it at some point soon. And on that note, at number 6, the Chief Officer, myself and Margaret as Chair have been out and about visiting teams. So we've spent a good few days out meeting teams. It's been a really great experience for me, real positivity, real focus on continuous improvement, and obvious that teams are really focused on providing quality care. Number 7, a staff health and wellbeing event on the 23rd of October. That was co-produced through the staff health and wellbeing team who created that day. And again, it sounds like it was a fantastic event and was really well received, really well reviewed, and something that we'll obviously look at building on in terms of staff health and wellbeing. At number 10, we have been lucky enough, lucky is not the right word, that a number of officers have put a lot of work in order that we could get £165,000 to help us with our homelessness prevention pilot, which is about training our teams to identify people who are at risk of homeless or who are homeless and signpost. So that's really good and will really accelerate our work around that. At number 11, there was a hackathon event. A number of us in the room attended. Was that last week? And again, really positive, bringing teams together from across the system to think about the future of health and care across the Glasgow system. And again, that I'm sure that there will be future events that are more around that prevention and early intervention space. At number 13, general practice funding, so £249 million announced. Officers in the process of looking at prioritising that funding, in particular looking at which premises require updating or we need other solutions around those premises. But also you will see that the funding is used for also IT solutions and staffing solutions as well. And then last of all, I just wanted to highlight at number 18, the quality improvement work. So that's in the context of the national work, but we also have officers led by David at the moment around our quality improvement approach within Renfrewshire. So taking a strategic approach to quality improvement, but very much aligned to that national strategic approach, and also linking in with GGC as well, building into that quality improvement strategy. So happy to take any questions. Thanks.
Thanks for that, Billy. I've got a few hands up. Come to Ian first, then Jacqueline. Ian McMillan.
Okay, thanks very much. Just a couple of comments and 2 questions. First of all, delighted to see the centre opening in Dargaville. I think that's absolutely terrific. It's a growing community, and it obviously needs some extra healthcare out there as well. One of the questions is I'm not entirely sure, maybe I missed it, just asking where the name Balerno came from, how that came about. The other thing I want to mention is about the SDS. I think it's a great initiative we've got going at the moment. I attended a meeting last week with the Carers Centre and Engage, just really to give me and my fellow Labour councillors a kind of understanding how it all worked on the ground. And there's certainly some really good work going on, because as we all know, SDS can be a bit of a minefield. You know, when somebody says, "Oh, you can employ somebody," and you're like, "What? What do you mean I can employ somebody?" So it's very, very complicated, and these people are really doing a really great job. And the women that's based at the care centres is doing some exceptional work. So I think there's still obviously room for improvement in its early days, but I think we're doing really, really well. Pleased to see yourself, Margaret, getting out and about. 100 years ago, when I was the chair of the IJB, suddenly the health issues descended upon the council, and I had absolutely no idea what was going on. But it was really, really good to get out and about and meet the staff and find out what these, sometimes to me anyway, obscure services were all about. So I think that's good, because I think sometimes the IJB can be some kind of mythical creature that nobody knows anything about. So the more you can do to get out and about and put a kind of human face to it all, I think that's really, really good. The other question I've got is about delayed discharge. You know, I'm really pleased that Renfrewshire is up at the top of the table, and I've said that continually over the last few years. I did put a wee bit of doubt in the thinking about it at the last meeting, and I'm going to continue with that theme. I just want to make sure we're not just being driven by figures. And I know that there's a lot of pressure coming from Holyrood to try and make sure, the figures are good. But my worry is that sometimes people might just be getting sent home and they don't have adequate care. I've heard about 2 or 3 recently, and I'm saying, well, that's great, we're top of the table, fantastic. But is there a desperation to stay at the top of the table, and we're maybe putting people out too early? So I just want to make sure that's not happening. I know there will be people who slip through the net, inevitably that there will be, but I just want to make sure that we're not just not being figure driven, and we need to remember that these people are human beings, and if they're getting home, they have to be comfortable from day one, not something that's going to happen in 2 months' time. So that's my question. One, where did the name Belair know for? That's just really general nosiness. And secondly, the meeting about the delayed discharge. Thank you.
Thanks. Yeah, I'll hand over to James around the Beleno, but while I've got the mic, I'll just maybe respond to the delayed transfers of care question. I think in terms of delayed transfers of care, I think I've said, certainly I've come from a place where we were in the opposite place around the number of people who were finding themselves in hospital for far too long. I know the impact that has on those individuals and families. So when people are in hospital for too long, essentially that means that people are more likely to deteriorate, are at more risk of falling, are at more risk of developing being confused by their environment and so on, and are more likely to deteriorate and then require more care when they are discharged, but also have worse outcomes. Not to mention then obviously the pressure on the system in terms of people at the other end, at the front, what's called the front door and the back door of the hospital, people at the front door of the hospital not being able to get into one of those beds. So there are really good reasons that I think we should be really proud around the number of delays and our performance. I would like to see the rest of the system being able to achieve that level of performance. And actually, I think in terms of specifically answering your question, are we discharging people too early? People are only classified as delayed once they have been declared medically fit. So once their treatment has been declared over from a medical and a nursing point of view, it's only at that point that they are declared as a delay, and it's at that point that we support people to go out. So hopefully that gives you some reassurance, Ian. I'll hand over to James around the Beleno question. Thanks.
Thanks for that. No, it's part of the kind of early engagement work with the development of the new site. We held a couple of engagement sessions with the public. There was a number of kind of historic references to previous buildings in the area, and there was a number of new parts of the development that have the name. So it was to really kind of tie in that kind of local connection and ensure that you've got that sharp distinction between the new facility and the existing health centre, Ian.
Thanks for that, James. I didn't know that. Before I bring Jacqueline in, though, I do think Ian's question around delayed discharges is a really important one, because I think your question stems from things I hear a lot, that there is sometimes a public perception that being in hospital for longer is positive. But actually, and I'll turn to some of the medics and social workers in the room, there's a huge amount of evidence that shows that staying in hospital environment for longer than necessary is incredibly damaging. And I think Billy's described quite clearly that the decision for readiness to discharge is a medical one or a clinical one, and then the decisions around what social services are needed to support that person come separately. So, but if that individual stays in a hospital environment beyond the period they need to, then their health typically deteriorates. And I think that is not necessarily particularly well understood by the public. So I think it's really important that as a partnership that we're all quite clear around the objective around delayed discharge. It's not about getting people out of hospital. It's ensuring people are in the right place for their need. If they need to be in hospital, they should stay in hospital. But it's a really, really important question. So thank you for that. Yeah, do you want to add to it? Because I think, John, that is important. And then Jacqueline, if it's okay, I'll bring you in shortly.
Thanks, Chair, and I'd like to kind of endorse what you've just said with a wee qualification. I think that the term delayed discharges actually dehumanises the process that individuals are in. And if you listen to Billy, he talked about delayed transfer of care. And I think we want to think about what the experience for the individuals that Councillor McMillan spoke about. The first bit is, it's absolutely right. People should only be in a hospital environment where they require medical interventions that requires that level of support. And the locality teams and other teams within the Health and Social Care Partnership who are responsible for assessing the assistance of transfer back home or to a future care placement actually work really closely together. So whilst the decision about medical fitness rests with the clinicians, the social work staff are actively involved in that agreement to transfer. Now, there will always be occasions, Councillor McMillan, where individuals will get home and we will realise that the package of care is not what they actually require to be there, but it would have been based on a professional assessment, and they are generally robust, but people can change very, very quickly. The really important thing for me is that we get individuals out of hospital back to a safe place for them. And part of that's about getting them back to somewhere they feel safe, where they feel secure, that they know, and they are able to move around safely within their own home with the appropriate care. So I genuinely don't believe that in Renfrewshire, this has ever been about being at the top of the league table. This has been about getting the right care for individuals at the right time in the best place possible for them. So I want to endorse all those comments, Chair, but also just think about, as a health and social care partnership, about how we speak about those processes that everybody measures us against. And actually, if we can humanise and show what's happening for those individuals, I think you then understand better. This is not a race to be number one in a target. This is to provide the best quality of care and support to individuals in our communities or in further residential care establishments, for example. Thank you, Chair.
I really appreciate that additional context, John. Thank you. Jacqueline, thanks for being patient. I'll bring you in now. Thank you.
No problem, Mags, thanks very much. Yeah, it was just a point that Ian had made as well about the visits. It was really good to see you and Billy out and about, and there's a real energy about it all. And, you know, I think that's infectious because, and I'm saying that while I sniff, but, you know, I can see that there's lots of posts on social media and, you know, other organisations seem enthused by the visits as well and happy to receive you. So they've been well received. So that's really positive to see. And my second point was just about the homelessness pilot. I think that's really positive. It's similar, you know, to the patient story. I think, well, that's NHS. I forget what we're calling it, but you know what I mean. The video that we just watched. It's a similar kind of theme in terms of prevention and early intervention, because frontline staff are going to spot these things, you know, quicker than other people might. And again, it's a good example of partnership working. So really pleased to see that. And that was all. No questions, just a couple of comments.
Thanks, Jacqueline. Yeah, it's funny that a couple of people have picked up on the visits. I've learned a lot, I have to say. So I think perhaps as we move forward, we could maybe do more, not just me, perhaps other members that want to see a bit more hands-on what's happening. They don't need to be as intense, but we'll look at that going forward. I think I've got another one scheduled in January time as well. Pauline's team. So look forward to seeing more hands-on work. In terms of Billy's paper, we're just noting the updates provided today and particularly around the national policy updates as well. So content to note those items. Thank you. That takes us on to item 5 of the agenda, and it's the in-year budget monitoring report. So I'll hand to Sarah for that. Thank you, Sarah.
Okay, as usual, I won't go through the report in great detail because I'll assume that you've read the paper. So it's positive in that we are moving to a reduced overspend. It's still a significant overspend, but we have reduced the overspend from that initially projected in March of this year, and we're now projecting a £5 million overspend, and we hope that that will reduce as the year goes on, and the work that we're currently taking forward will have an impact on that. So just to highlight a couple of areas in the paper, the main reason for the movement in the position is due to employee costs, where the impact of vacancy management processes are having quite a significant effect on the bottom line, and we're managing that very carefully because obviously there are some posts that need to be filled immediately, and we do that as quickly as we can. But also the impact of prescribing, and I'll talk about that later in the paper, that's having a major impact on the position. So if you turn to section 5, there is a lot of detail in that section about prescribing, and I tried to highlight the reasons for why prescribing is moving. It's a really volatile budget. It's very, very difficult at the moment to project where that's going. In previous years, we had an understanding of what volumes were looking like and what prices were looking like. That's all more or less been blown out of the water compared to where we were this time last year. For example, we put in a 10% increase based on the information that we had to hand, and actually volumes and price are nowhere near what that is actually turning out to be at the moment. However, what I would say is it could change. It could change due to circumstances. If particular drugs go on short supply or whatever, that can have a massive impact. But one of the reasons that we're doing so well at the moment is because one particular drug, I can't pronounce it, maybe Stuart can, and we'll call it DAPO, I think. That's the short name for it. A diabetic drug has dropped from a huge price of roughly 50 plus pounds an item to about 13 because it's come off licence, and it's likely to drop again. So that's having a really positive impact on our budget. And when we set the budget, we didn't know that was going to be happening. So all of that can have a real impact on where we're going with prescribing. And that's also reflected in the later paper that you'll see. But in 5.6 in the paper, I've tried to show what does that actually mean in terms of a small percentage change to the actual outturn. And you'll see a 1% increase in prescribing could mean 880,000 of an increase in spend. And the converse is actually would be a reduction to that. So it's these wee nuances that we need to take account of when we're creating the budget. But it's not behaving as we thought it would behave. It's not just Renfrewshire, so I take quite a lot of comfort from that. It's right across the piece, not just in Greater Glasgow and Clyde with the other HSCPs, but right across Scotland. But it's just a huge caveat that this can change. So it's just to note that at the moment. And then the final part is just to talk about reserves in the last section in 7.2. There's a table there that shows what we think the reserves are going to look like this year, and that's based on what is the projected outturn likely to be and how much we need to draw down to deliver a balanced budget by the year end. That will change as the year progresses. If our overspend reduces, then we will require less reserves, which gives us more for next year, which would be really helpful going forward. However, that's subject to a lot of change. We've got winter coming up. Things can happen in winter where we require more staff on the ground. We have a lot of sickness, you know, depending on if we have to have more cover, etc. So all of that starts playing out, and we won't know that till about the end of February when we start seeing those costs coming through. So that's all I was going to say today, but happy obviously to take any questions.
Thank you for that, Sarah. So this is our usual report, which updates where we're at the moment. And as Sarah set out, a number of things are moving during the year. I've got a question from Ian McMillan. Ian.
Sorry, I should have said this at the beginning of the meeting. I mentioned of St Vincent's Hospice in here. I'm an ambassador for St Vincent's Hospice, so I've looked at it. I don't think it stops me from taking part in any debates. So sorry about that. I should have said that at the beginning. The questions I've got, you know, listen, the prescribing, it's good to see the costs coming down, and I don't think I fully realised until recent times how much of an impact these costs have on our overall budget. And I think the general public would be quite surprised by the cost of prescriptions. The two questions I've got is, and I think I probably know the answer to this, but I just want to just confirm it. There's money there that's allocated to Women's Aid. I just ask, is that the cost of their whole service, or are they still dependent on money from other sources? wasn't that long ago, I went up to see them at their premises in the south side of Paisley, and I was really impressed with the work that they do up there for women and their families. And it's a really welcoming environment. So I just want to make sure, you know, that they're sufficiently funded, and they've got enough money to do what they've got to do. And the other thing is the transport costs. How much of a concern is that? Because that's something we hear. Wearing my councillor hat, we hear very often in other services how much of an impact the rise in transport costs so it has on delivery of council services. So how much does the rise in transport costs have an impact on the services that we provide as an IJB? Thanks.
Yeah, I can answer the transport costs, then I'll pass over to John for the Women's Aid, because that's not delegated to adult social care. It sits within the council, although we do report on it, one of those complexities. So, and again, most of the transport costs also sit in the council, so it's only a marginal amount that sits with us, and we receive a recharge from the council for that on a regular basis. So depending on the costs of fuel, etc., as they go up, the recharge from the council annually will increase to reflect that. And obviously, depending on the number of buses that we're using, whether some of our services are open or closed, that's also reflected in the costs that transfer over to us. So it does move, it's a movable feast, but the council does recharge us for any increases. Hopefully that answers that for you.
Thanks, Councillor McMillan. In relation to Women's Aid, they're a complicated organisation in terms of the way they're funded. So the local authority provides money to provide a sort of general office running some of their core staff, but we don't meet all of their core staff because they are a federated organisation and receive grants from a number of other places. In Renfrewshire, we pay Women's Aid money to ensure that they provide a first point of contact. Where women and children flee violence in the house, Women's Aid then can access additional support through housing benefits to provide that housing support service to those individuals. So it is very responsive to that. The question of whether or not the core fund is adequate, I would love to be able to offer more, but like most places, we actually have limited budgets, but we do take into consideration the pressures that Women's Aid operate under each year. They are a key partner and we look where we can to enhance it. Thanks.
Thanks, Ian. And Ian, I know you've mentioned your role at St Vincent's before and there is no budget decision, so I don't think there's any issue with that. So thanks for flagging.
Just always just like to mention it, just in case.
Becky, bring you in next.
Thank you. Thank you. I've got the mic, so I'll say thank you. It's a pleasure to join this IJB and to be here this morning. Thank you so much for the paper. As a new person reading it, it's really helpful. I think it explains a lot of things really helpfully, so thank you. My other job, my background is as a clinician and a prescriber, and so I appreciate that this is not an issue that is unique to Renfrewshire, but it was really helpful to get that information on you on what slight changes in prescribing can do to our budget, and especially give the example of that that particular drug. So I suppose, and it might be a question for Stuart actually, so I suppose, and I have asked this in other forums in the Health Board as well, do you think are you happy enough that the people who are doing the prescribing are as aware about this as a budget issue as they should be, and what changes they can do that can actually have a big impact on our budget? Thank you.
Sorry, yeah, thanks, Becky. I think it's probably easier. There's a whole programme of work, I guess, within the HSCP, which Sarah leads from a finance perspective, looking at what we can do in terms of change programmes to implement all of the board-wide cost efficiency measures to try and reduce prescribing of more expensive drugs, stop drugs that are of limited clinical benefit, undertake polypharmacy reviews for people who are on multiple drugs, try and stop anything that is potentially causing harm. I think that's the other message we do get across to our clinicians, and I guess GPs in primary care are kind of very well aware of this as generalists, that actually too much medication is actually often harmful. So often people start medication, it never gets reviewed and they never stop it. So I guess we try and frame this as not only being a good thing for reducing the prescribing budget, and that every pound you spend on drugs that you don't need to be spending is a pound you can't spend on a district nurse or a kind of frontline staff member. But also actually it's about quality improvement and avoiding drugs that we know can lead to harm and people being admitted to hospital. So yeah, I think GPs are probably more aware than most, and constantly when we prescribe, the clinical systems show us the cost of everything we prescribe whenever we prescribe it. So I guess there's constantly that awareness of what's going on. We've got Script Switch, which is a tool that will prompt you to swap to a more cost-effective alternative within our clinical systems, and we've got our pharmacy teams who spend quite a big part of their time purely focused on cost efficiency and cost saving measures. So I think there's a lot of work going on. I think we probably we never rest on our laurels. We're constantly revisiting that and looking at kind of what the areas we should be focusing are. Our lead clinical pharmacist, who is coming into post but has moved from another HSCP, is also kind of well aware of that and very much linked in. And I think the really good support that we've got is from kind of our elected members and councillors who are kind of on board with this and understand that this is a really important thing for the public to be aware of and to support us in making those changes, because ultimately people don't like changing their medication. They're used to taking a tablet that looks one way or a capsule that's of one colour, or that you take once a day instead of twice a day. And so any changes like that can drive a little bit of anxiety. But I think the fact that we've got kind of broad support and understanding that this is something that we can all do collectively to try and sort of assist with the budget across all of our services is really good. I guess the last thing I would just say is there's a little bit of anxiety around new medications, and I think the unknown probably for me is some of the weight loss medications that are currently used for type 2 diabetes, the injectable GLP-1s, so like your Mounjaros and your Ozempics that people are broadly accessing privately currently. There will be very limited access through the board probably next year, and it will be initially quite tightly controlled. But I guess as we move forward years ahead, there's a concern and a risk that those drugs may become quite a big part of our kind of budget going forward, and it's an unknown. So I think that's why it's a constantly work to try and do everything we can to prescribe the most cost-effective medication, but also stop medication where it's not beneficial or harmful.
Thank you, Stuart. Thanks for the question, Becky. Jamie, bring you in next.
Thank you. I'm in danger of stating the obvious here about reserves, but I'm thinking it's IGB policy to maintain a 2% reserve in the same way that IGB policy to have delayed discharges not run on and every other policy that exists as well. But we're running down reserves here. That's where that's going. And then I thought there's no plan to top up the reserves, so I'm stating the obvious there. I think the thing I'm really interested in is well, of course, it seems like saving money for a rainy day when there's services over here that need it. It's quite clear where the decision to be made there is. Do you have any sense in terms of, I guess I'm pulling to a national picture to try and understand to what degree is this IGB behaving in the same way as every other? Are there any IGBs who are successfully managing to maintain and top up reserves over this period? If you don't know, that's fine as well. But I think just for the sake of understanding and stating the obvious, which is we are breaching our policy here, just checking that we're super clear on that, and trying to understand if that's unique or not.
Okay, thank you, Jane. So we are actually in a far better position than most other IGBs across Scotland. We do still have a small amount of reserves, and yes, we are in breach of our own policy at the moment. The intention to top up reserves would be wonderful, but at the moment we're using reserves to deliver a break-even budget. So until we're at that point that we're financially sustainable, and any underspends that we would have in year and plan to move to reserves, we won't be in that position. But we're not unique at all, unfortunately, but we are amongst the minority that still do have reserves. So hopefully that's okay for you.
Sometimes stating the obvious is needed just to make sure that we all understand where we're at, though. So that's fair, Jamie. Thank you. I don't see any other hands or questions. So, Sarah, in terms of this report, we're just noting the position at September this year and the projected year-end position through to March 26. So we're just noting that this morning. Thank you. Takes us on to item 6. on the agenda, which is the mid-year assessment of budget pressures. So I think we're just extending the discussion that we've just touched on there. So Sarah, hand back to you on this one.
So apologies to everyone. This is a really complicated paper to have written, and I was pulling my hair out, and thanks to my team for working so closely with me on getting this together. It is a really difficult thing to do mid-year when you do not know what the budget announcement is going to say, and you don't know what the UK budget announcement is going to do in the midst of you writing this. So what I would say is it is all heavily caveated, and until we know what comes out on the 13th of January and the impact on IJBs, this is the position as I know it today and what I think it's going to look like. I think it will change significantly, either up or down, I don't know, but this is the position as at today. So really, really clear to everyone, this is not what it's going to look like next year, but this is my best estimate. So the first area to look at is really to show that the original scenario for this year was in section 4, we highlighted as being an overspend of 8.9 million. And in the previous paper, we talked about why that position is improved. And then, and this is quite a complicated section, and I really apologise to the complexity here. It was very, very difficult to show this, so apologies yet again. This is showing where we are in delivering the savings to date. So last year, members will recall, we agreed 14.5 million of savings to be delivered over 3 years. So for the current year's savings of roughly 7.8 million, we're on track to deliver those in 25-26. However, the 26, 27 and 27, 28 savings are currently under review because worsening patient and client frailty amongst acuity of need, etc., putting a lot of pressure on services, and the likelihood of us being able to deliver these savings is highly unlikely. So in this paper, what we've tried to do is set out what is that going to look like. We don't want to overstate what we think we can deliver, better to show the reality of the situation so members are aware of exactly what that gap will mean to us. So what we've tried to do in section 5.5 and 5.6 is to show what that change actually means. And apologies for the complexity of this, because without all the detail sitting behind it, it's quite hard for you to understand and for me to show what that actually means. But essentially, it basically reduces our level of savings that we'll deliver and increases the gap going forward. So the figures that you'll see in the remainder of the paper take account of the reduction in the likelihood of us delivering those savings. So then if you move to section 6, there's a section there on, and this is again a really complex area for members to get their head around. It's certainly really complex for me to get my head around, along with most other CFOs. And this is to do with how the funding comes into the council. And it comes through GAE, which is grant aided expenditure. And this year, it came to light that a number of the indicators used for adult social care were out of date and based on 2001 census data. So if you can imagine that it looks quite different, 20 odd years later. So, and it accounts for £2.3 billion of expenditure that comes through our allocations. So that has been reviewed. COSLA leaders have agreed to update the system and to use the new indicators. What that will mean is that there will be some councils who will have an increased allocation on the basis of this, and some will have less of an allocation. And we're currently working through that. We don't know what the impact of that will be for Renfrewshire as yet. We're hopeful that it will be a minimal impact given our deprivation stats and also our population growth, but it is impossible to know at the moment. So I'm not going to give you any figures because I don't know and nobody actually knows. The Scottish Government are working closely with COSLA to try and work out what does that look like based on the 25-26 budget, so that we've got an idea of roughly how much it could go up or it could go down. But what the important thing is, and this is the very technical bit, is that the floor mechanism will be used so that this will happen gradually over a number of years. So if you are losing £10 million, you wouldn't lose it in the first year. The floor protection would kick in and it would be gradually impact the change over a number of years. So whilst it's a concern, it's not as big as it could be, but we need to wait and see till we get the figures and to understand exactly where that places Renfrewshire, but also how the council will treat that, because ultimately it's how the council pass that through or not to ourselves. So that's really, really complicated. I hope I've tried to explain it okay in the paper, but it's all to do with statistics and all the rest of it, which is just way out of my comfort zone. I am not a statistician, so that's as best as I can do on that one. Then the next section is future pay settlements. So when the Scottish Government agreed the pay award for NHS staff this year, they agreed it at 4.25%. However, as you'll see in the paper, they also included the impact of potential changes to CPI, inflationary increases. And unfortunately, at the moment, well, fortunately for staff, that's actually sitting at higher than the 4.25%. It's currently sitting at 4.4 and potentially 4.5% by the end of the calendar year. So that means that there'll be an additional cost burden on NHS, for which we're not 100% sure that we'll get full funding for. I think if we will get some funding for it, but it won't be for the full amount. So there's uncertainty in that. That then has an impact on the next year's funding, because that then changes the differential between the agreed percentage increase for next year. So all of that starts having an impact on our budget. But we await the outcome of that. We won't know till next year, and we won't know what the level of funding will be or the potential shortfall. So as you can see, this paper is really complicated. So apologies yet again. I keep apologising. I think I'll have to stop with that, because otherwise that's all I'll be saying. So if we then go into the section on prescribing, we've already discussed that in quite a lot of detail in the previous paper, so I won't go into that in much detail here. I think the important section to look at is section 6.6.2, where you'll see the graphic which shows the original gap that we thought for 26-27 and 27-28, and the revised gap, and that takes into account the fact that the approved savings may not be delivered in full, but also the main impact of that is the reduction in the prescribing. Again, that may change depending on our intelligence that we know in the new year. Is prescribing still following this low trajectory or not? So again, I will update that at that point. But at the moment, it's really positive in that the projected overspend is coming down. However, it's still a huge, huge gap that we need to find. That's still roughly 12 million for next year we need to find to get recurring balance. The next sections basically talk about reserves and financial recovery. And on the 12th of December at the development session, we'll bring to you a lot of detail on what financial recovery could mean for the IJB, and we'll work our way through that with yourselves, and obviously answer any questions that you would have, and hopefully feed more information into the document. It's actually proving to be a very interesting but difficult thing to do, because there's so many different nuances to understanding what does that actually mean. And when you start digging into it, the questions become more and more difficult. So we'll hopefully pull all of that together for yourselves so that you've got an understanding of what does actually financial recovery mean, other than everything becomes unplanned. So everything is reactionary, which is not where we want to be. And then finally, just a section on the IJB annual audit report, again, just emphasising that there's a critical need to identify recurring savings and reductions for us to remain financially sustainable. So, end of my paper. Happy to take any questions.
Thank you, Sarah. Thanks for taking us through that. Got a few hands up straight away, so I'll come to Jacqueline online first. Thank you.
Thanks, Mags. Thanks, Sarah. Yeah, it is a complicated paper, but you make it as clear as you possibly can. So thank you for that. My question's about 6.3, the grant aided expenditure, Sarah. I just wondered, has there been any chat at COSLA or amongst CFOs about Scottish Government directing local authorities to give any money that may come straight to the IJBs? I know I've been here before where there's been dubiety about, the money being directly handed over. So I just wondered if there's been any chat about that. From what you've said, I gather not, but I just wanted to double check that. Thanks.
So we always remain in hope that the budget letters that come state that. However, they may state it, but you cannot formally direct or legally direct that to happen, but we would hope that we do have a really good relationship with the council in Renfrewshire, and we do talk obviously, and this is a big impact on council services. So we would hope that any positive or negative reductions we can discuss in full with the council to see what that impact would be. But it's not yet clear what the narrative in that letter will have. I will have a direct ability to shape that letter in my role in the National CFO Executive, but only a limited amount. But we are hopeful that that narrative that's usually in the letters is played out both in the health and social care budget allocation for this year. Jacqueline.
Thank you. Thanks, Sarah. Thanks, Max.
So the letter, even if it's fairly clear, isn't a direction as such. And I think that was your question, Jacqueline. Thank you. That helped me understand as well. Ian, bring you in next.
Yeah, thanks very much, Sarah. And you don't be hard on yourself. You've done a good job in trying to make us lay people understand what the hell's going on. So it was fine. When I seen the projections up to the year 74, 75, I immediately thought of 1974 to 1975, but by God, that's a long, long way off. I don't know if many of us in this room will still be around at that particular time. But in all seriousness, when you see 55% again up to that figure, it's quite frightening. It really, really is. And God help whoever's in charge of the IGB or whatever it's called nowadays, trying to cope with that. Earlier on in the report, it spoke about prevention. I'm certainly, when that was mentioned earlier on today, I'm a great believer in people taking their own health responsibilities and making sure they're fit and healthy and have a long life. And when they get older, they're still relatively fit. And I still think that's something we could do more about. I think we all as individuals have to take that responsibility, but also councils and health boards need to do that as well, trying to encourage people to stay fit for longer. And as we mentioned earlier on, the reserves are really a concern. We all like as individuals to have a wee bit of money in the bank for a rainy day, and IJB's no any different, and it's worrying that they're getting really, really, really low. A lot of people, I watched the budget announcement on Wednesday. Very interesting watch for a political anorak like me. And not that I expected Rachel Reeves to say, "Oh, I've got this X amount of money for Renfrewshire IGB," but I was hopeful. But of course, there's money being delegated to the Scottish Government, and going back to the last meeting in September, the motion that was put up very much was hopeful that there could be money available from either whether it's the UK government or the Scottish Government. And I think we're all holding on with bated breath to find if that's going to be the case. In the year of an election, I'm even more hopeful, but we'll obviously wait and see what happens in the next couple of months. But as I say, it's worrying times for us that are involved in this, but as I say, hopefully there's a glimmer of hope out there. But thanks very much for the paper. Thank you.
I think this paper is helpful. It is a bit of a guide through the public finances and the variations that can exist in them. So I think it probably serves as quite a good reference paper for a lot of us to understand why there are fluctuations. And I know that's a question that comes up in here. Why do we not know? Why does it change? And this does set out the whys really well, Sarah. So thank you for bringing that to our attention. The recommendations on the paper are set out at section 2. I don't think, given the questions, that I need to go through and read these aloud, but we are effectively noting all the items at section 2. So if we're content that we note those, we'll take that as agreement. Thank you. So that concludes paper 6, item 6. Takes us on to item 7, which is our Sustainable Futures, and it's a programme update. Frances, am I handing to you for this one?
Thank you. So this paper provides a further update on our Sustainable Futures programme activity and proposed next steps, both to support the IJB's financial sustainability in the short and the longer term. The paper has some of the significant financial challenges detailed in it, but we've already covered these in more detail in the finance papers today. But I would highlight, because it is important context in terms of this paper, that whilst the current projections are more positive than we'd forecast, as Sarah's very clearly highlighted, the financial position is just exceptionally volatile, and it's likely that those projections will change due to the uncertainties that exist. And the need to address our future sustainability is really clear in terms of the 24-25 external auditors report, which noted the difficult decisions that are required by the IJB. And this is also reflected in our risk register, where the risks relating to the financial position remain at the highest level of risk available, even taking account of the updated financial position. So in relation to the saving proposals that we've developed and delivered, are being delivered by the HSCP, the report notes a number of updates, namely that following the September IJB, where members were unable to reach an agreement on 8 of the 9 proposals, the value of those 8 saving proposals, which was around £2.1 million, will be added to the financial gap for 26-27. In relation to the savings totalling circa 14.5 million agreed at the December 24 meeting, we note good progress delivering the 25-26 allocation of those savings, where we're already have delivered 7.5 million of the 7.8 million target that we agreed in year. And at present, as Sarah's already covered in more detail in her report, it's anticipated that a balanced budget can be set for 26-27. However, as we've covered today, that will require the drawdown of the remaining reserves, and it's also subject to that ongoing financial uncertainty, which Sarah has talked about. However, the report does ask the IJB to approve the rephasing of some of our savings, and these are outlined in 4.4 of the report. And furthermore, we do note a high risk that there will be a significant shortfall in the delivery of some of the savings that we had asked for approval for back in December 24. And as Sarah already covered, these are largely related to substantial reductions in the savings that we think we can derive from care packages relating to older people and physical disabilities following review. And her report, we note the range where we think that potential reduction in savings was picked up in the mid-year assessment. So we think that will be between 1.87 million to 2.06 million reduction in what we can deliver in the savings. So whilst the long-term focus is on wider transformation of services, and we hope to bring more detail on that to the January meeting about the work we're doing, this report highlights the work that we're doing in the that we need to do in the short term, and that needs to be a priority to ensure the financial sustainability of the IJB. And it is important to note that some of the short-term decisions that we're required to make may conflict with the longer-term objectives that we're looking for in the national direction that is set, but they are really critical to achieving financial balance and reducing the likelihood of us going into recovery. So reflecting this position, 5.4 in the report asks the IJB to agree a number of short-term actions. One, that we further develop more recurring savings that we'd bring back to the IJB for their consideration. Also, that we develop an integrated impact assessment for financial recovery, and we think this is really important. We talked about it at the last meeting, to allow members the required context to fully understand what the impact of entering recovery when considering alternative saving proposals or actions that are presented to them. Also, that we revisit the 8 proposals that the IJB were unable to reach a decision on at the last meeting. But we would note that we'd look to review these and there might be possible revisions to the proposals that are presented. Also, alongside the focus on recurring action, we also will continue to identify non-recurring action to help manage demand and spend. And then also, as following on from the discussion at the September meeting, we want to continue engagement with our partner organisations around potential opportunities for monies, either one-off or recurring, that could allow us to maintain our performance or support more transformational activities in the prevention early intervention space. But this would be reliant on business cases to link the investment to the benefits that we'd be looking to achieve. Alongside the actions that we're asking for approval today, the SMT continue to progress our VER, our voluntary redundancy, voluntary early retirement process. But I would note that some of the requests and decisions around that are subject to some of the saving proposals that we brought in September and how they're considered at a future date. And we've also noted within the paper some of the additional oversight groups that have been established to help us monitor the delivery of the financial savings that we've agreed. Finally, I just want to, as I've mentioned already, we are undertaking scoping and baseline work to inform a longer term, sort of more transformational approach, and we're looking to bring more details of this to the IJB in January. But happy to take any questions. Thanks.
Frances, thanks very much for the paper. There's a lot of detail in there, and I think it reflects a lot of work that's going on in the background. So thank you for bringing that to us. I've got Jacqueline first.
Thank you, Mags. Thanks, Chair. Yeah, thanks for the paper, Frances. It was just a bit about rephasing. I know these are savings that we've agreed before, and you know that there is a level of detail in the paper, but I think you know, I probably are looking for a wee bit more detail about what it really means. Is it simply service redesign, or is there more to it than that? I know each section's different, so it might be that you need to identify each particular service.
Yeah, there are a range of reasons, which I realise that we've not gone into detail, but I can pass over to the different operational leads to talk a bit more, for example, about some of the capacity pressures around the out-of-area placements. There's some other areas that we can do. Would it be Laura in relation to enhanced observations and out-of-area placement, if that's okay?
Yeah, that's Frances. I'm not sure, Councillor Cameron, that's what you're looking for detail in relation to. I think it was more of the service redesign, but I'm happy to speak to the two areas.
Sorry, Laura, sorry to interrupt, Mags. It was all of them really. Enhanced observations, not so much, but the out of area placements definitely. Thanks.
So that's one where we have people from Renfrewshire being supported out with the Renfrewshire area in specialist high cost placements. And our aim was to support people back to the Renfrewshire area. And as you'll know, that we have some of our own internal services that provide support to individuals and families whose needs are very high and complex. And the aim was to support people to come back into the Renfrewshire area. So there are two areas within that the team have been working with. One with the families, because there are choices related to this in terms of how people spend their budgets. So looking and how we can enhance people's outcomes, particularly when they're travelling long distances out of areas. So that was the first thing, to look at better outcomes for people within their own area, reducing transport costs and reducing costs on external placements. The second part of this is related to the assumption that we will have capacity within our own internal services, and at this point in time we don't have capacity. So when we looked at the proposal, there was capacity, but unfortunately due to the demand in relation to transition, families in transition and young people in transition, those places have been taken by families, so are no longer available to support out of area placements. So we'll continue to monitor that, and when places do become available, we'll work with those families to support transition back to Renfrewshire if that's appropriate.
Okay. And Billy was going to commit around extra care housing and care at home.
Yeah, thanks, Francis. So Lisa's on annual leave, so I'm happy to pick up the questions around care at home and extra care housing. So in terms of the care at home redesign and extra care housing, I think the team, having looked at what was initially proposed, have recognised that actually if they do something more radical and fundamental, essentially around the redesign of those two and the interplay between those two, that actually the outcomes will be better. And also the savings may actually be more. So by delaying the implementation, the outcome should be better, and the savings may well be more in the longer term. I think, though, it's probably worth me also picking up on, I think it's section 4.5, which is around the risk of some of the savings, and it was obviously called out in Sarah's paper as well, which was around that 7.5% reduction in care packages for both physical disability and older people's care packages. So again, the team have been away and done much of that work. Over 80%, I think, of those care packages have now been reviewed, and only a small proportion of those savings has been achieved. And I think there's a combination of things there. Sarah mentioned them as she went through the paper, in terms of the backdrop is a rise in the number of older people, a rise in the complexity of the needs of those older people, and also similar sort of picture for those with physical disabilities. Therefore, the work that we're looking to do, the best we may hope for around some of that might be to flatten the curve, the demand. And certainly my experience of implementing, for instance, a reablement model has been that we were able to flatten the demand. So the projected demand was going steeply upwards, and what we were able to do was avoid, so there was a cost avoidance of over £58 million, but there was no concrete savings, if you like, in-year savings, and I think that's probably what we're seeing and feeling with this. So I think, again, the work is being done, just to give the IJB assurance that the work is and has and continues to be done, but we will need to relook at what that looks like. There are some other things that we've put in place. So in terms of high cost care package scrutiny groups, Laura chairs one, Lisa chairs one. I'll be chairing one for those very high level care packages, and we're also looking at a fair access policy as well across all of our care assessments. So hopefully that gives assurance to the board that the work's been done, but the outcome is not as we'd anticipated. Thanks.
That helpful, Jacqueline. I see you nodding. Thank you.
Yes, thanks, Max. Thank you. Thanks everyone.
I've got Ian, then Kath. Ian first. Thank you.
Okay, thanks very much. Just want to, first of all, just want to clarify the timescale for all this. I know I've got a meeting in December. No, sorry, January, and then we've got another one in March. So if you can just maybe kind of tell me the exact what's happening at the meetings with regards to this issue. The other question I've got, and I think the key part is for me anyways, in 5.4, we're talking about partner organisations. Can you tell me if any discussions have already taken place with partner organisations? And although I don't expect you to tell me any specifics if there have been any discussions, but what sort of savings are we looking for them to make or to help us make? And also, I just quickly caught the press this morning, and some journalist has done their homework and read these papers and seen that the 8 proposals that we had in September have not went away. They're still very much on the table. And I think at the time there was people had spoke to me and contacted me and said, well, what exactly happened at that September meeting? I tried my best to explain, but I did say to them that these proposals have not went away. They'll come back in one form or another. And again, without getting into the full details, I know we'll be getting further information on these 8 proposals, but do we envisage much change to them? Or will they just come back in exactly the same form? Thank you.
Thank you. In relation to the phasing, certainly in January we're committing to bring the paper around the transformation approach, but it's unlikely that we would be bringing specific proposals. We would be bringing more detail on how we're addressing the proposals, the timeline for those. Billy might want to add a bit more around that. I guess one of the things that we're mindful of is that to be able to present the proposals and to give members the context that they need, as I've already mentioned, the impact assessment on going into recovery feels pretty critical to that and bringing that to members. And in terms of the 8 proposals, we, as well as having that context about the impact of recovery to look at, we've not yet revisited those. Certainly, we noted at the last meeting specific recommendations in relation to Child Smile. So that is one that we would look at. And we would want to revisit the other savings. So we will need time to look at them. So I couldn't make a call at this point on how far they would change when they were brought back to members.
Yeah, thanks. So I suppose in relation to the transformation programme, as Francis suggests, it'll not be a list of things that we're going to be going on and getting on with. I think the reality of where we and others are in terms of that backdrop that I described, the demographic changes and the challenges across the health and care system, this takes cultural change, and that's not just cultural change within our sort of system, within our own teams and our own staff, and the way that we interact with each other and other agencies and the communities that we serve. It requires cultural change within those communities that we serve, and it is about co-production. So if we're going to do that properly, if we're going to really come up with solutions that are going to work in the longer term, we need to generate those solutions with those communities, with our staff. So really the timelines that Francis is describing is about us creating space over the course of the next year as we develop our new strategic plan for those conversations within communities at a locality level, within frontline teams, for them to work on the solutions that work for them within their own community context. I think, though, I have confidence that during those conversations, this isn't about sort of spending 2 years navel gazing. During the course of those discussions, there will be immediate action that will take place. Things will start to change in the way that we go about having those conversations and the way that those teams interact. So if we look at, for instance, what's just been going on across the health service across GGC in the system reset, for instance, Pauline and I have been on the exec calls on an evening, and the big thing that's come across is the change in relationships, the way that people are working together, working in a more joined up way, and inevitably that starts to uncover points of friction and waste and inefficiency. And so by generating spaces for those conversations, we will inevitably begin to make change, whilst we also come up with the concrete proposals of change, if you like.
Okay, Ian, I think you also had a question.
I had a question about partner organisations.
Are you able to pick that up, Billy? Or
But I think, Billy, you want to talk about, I know there have been conversations with our partner organisations since the last meeting.
Yeah, thanks, Francis. Yeah, sorry. So again, I see that Alan's online, and so again, I think we had a really good conversation. So I've spoken before about the importance of the third sector within that whole system approach. We heard an example this morning about that shift in the way that we have conversations with people, connect them into communities, and the third sector is a really important part of that. So yeah, in conversation with Alan and others from the third sector about their contribution and how we work together, Francis and I are working. What's that? Sorry. Oh, okay, sorry, apologies. And yeah, so apologies, that was about the opportunities for funding, Ian. So in terms of the funding opportunities, we've put bids forward. So there is Scottish Government slippage for short-term funding. So we've put a couple of bids forwards actually over the course of the last week. We're also in conversation, as we know, Renfrewshire perform really well around our bed availability. So because of our performance around delayed transfers of care and having low numbers of people in hospital, we have fewer numbers of people in hospital. So when that transfer happens, then Renfrewshire will be considered as part of the front runner in those conversations. Although at the moment, obviously, we've not got to the point where there's money transferring on a recurring basis. And then from a council point of view, what we're in discussions about are where there are redesigns, for instance, that affect buildings and things that are not within our budget, how we might get some benefit share in those discussions. So we've opened up those conversations. Apologies for misunderstanding the question around partners. Thanks.
Thanks for your question, Zane. Kath, we'll come to you next.
Thanks, Chair. I appreciate the sequencing today. Sometimes in meetings we perhaps lead with finance, as if finance is the most important thing, and then it takes a lot of time. Now, clearly finance influences everything else, but I think the sequencing today has made the quality of this item on the agenda much richer and kind of pertinent as well. In terms of timing, I'm kind of picking up on what you said, Ian, and I agree. I think the timing is important, and if I would suggest that the integrated impact assessment is, when I read the paper, this is the new part, I think, that can be a gateway to us revisiting previous discussions, decisions, looking across the landscape, and also the work that we're going to do in December around looking at risk appetite, because those are really important in terms of when we come to make those decisions. So I just wondered, Francis, if and I can see you nodding, is that going to be a priority for your team? And I know there's a lot on at the moment, but it does feel like this is an important gateway to making those better informed decisions.
Yeah, we agree that the impact assessment, as I've said, is really critical. It's not sitting with my team, actually, it's sitting with Sarah's team. So they're taking that work forward, but in conjunction with our operational heads of service.
Yeah, I think, as you say, it is really, really vital piece of work to be done. So I think depending on the outcome of discussions that we have at the development session and what work still needs to be done to be fleshed out, we would hope that to bring that to probably the March IGB at the earliest, because there is a lot of work. We wouldn't have it done for January because the papers need to be in at the end of December, so we wouldn't have enough time to turn around any comments or changes that you would want reflected in that. So it is a huge piece of work. We want to get it right. But what I would say is that it would be a document that would be a live document, and that we would need to amend it and change it as we would see fit. But it will be a helpful, hopefully a really helpful document to have in front of you.
Thanks for that. I guess I made the presumption that you would be leading on it, Francis, in your team, but that makes sense. But can you assure me that equity will be part of that assessment?
Yes, it will go through the same EQIAs, everything, although it's actually a very difficult thing to do because it affects everything. So it doesn't follow the same format that other IIAs can, because you can't do an EQIA on every single thing that you do. And by its very nature, it will be unplanned. So you can't have financial recovery that's planned. So it's all of these subtle nuances that we need to have these discussions and build in. But what we're trying to do is we speak to all of our professional leads, get their views of things. We've spoken to Chief Social Work Officer. We've spoken to a lot of people to try and get all of that narrated into the document. It's going to be quite a big document. But again, it doesn't follow the same format as others, just by the very nature of it, Kath. But we would hope to build everything that we can in, but you'll get an opportunity to comment on it. Everybody will. Okay.
Thanks, Sarah. Jamie, do you want to come in now?
Yeah, thank you. The thing I don't think this is just directly for you, Francis. I think it's for everybody, which is the thing I feel aware of just now is the level of distress that was in this room when we considered those proposals. and that came to email inboxes and that people experienced, and not only for people who were in receipt of services, but staff who were maybe looking at being redeployed or looking at redundancy, the conversations they would have had with their family, and then thinking, oh, are we suggesting that actually they might need to restart those conversations again? Maybe. The thing that I have in mind is that I think I'm sitting here wondering how we as the integration joint board can we / what can we do to prevent a rehash of the same level of feeling that people had in the knife edge feeling, where people left the meeting feeling like, oh, I think we're still getting the thing that we're getting, but maybe not for that long as well. And I don't know if that's avoidable or not, but I think it's maybe a challenge more widely for the board. It's not for you to write a paper that brings everybody together. I guess I'm sitting here feeling really curious about how will it be different next time round / will it be different next time round?
I'm not going to ask officers to answer that, if that's okay. I think what we are attempting as an IJB to do with the, Cathy, you referred to sequencing today, but talking about essentially building trust with each other and with the public, that we are being transparent around what we're trying to do, which was part of my decision back in September, that we wouldn't just automatically bring it back to this meeting. So we wouldn't just automatically retable those same proposals, that we would actually take them away and spend time to really get under the skin as to how do we take forward services, not just changes to services, but our services as a whole, to make them as good as they can be with the resources we have. And that is why we've sought this impact assessment across changes. It's why I've asked for a bit more information around prevention work that's happening. It's why we're looking for longer term plans of how we can spend to save or spend to improve services, would be a better way to describe it. And actually, how can we get investment that might exist in the wider system? So there are a lot of things happening here, but none of these things should be done quickly just because we had tabled them before, if that makes sense. So I think that's why I'm not really looking for an answer, Jamie. Is that all right? In the context of, I don't think they're ready to be brought back to have a different outcome. I think that would be my assessment of it. So we need to be in a stronger place, that the management team and the IJB members fully understand the implications of what's been brought. Kath.
Thanks, Chair. I think that's a really good summary. And I'd just like to add, picking up on Billy's point about culture and bringing people with us in this conversation in perhaps a way that we haven't done, with the best of intention, and including the third sector more clearly in those decisions, and also the implementation of it. And I'd just like to point to, you mentioned in your Chief Officer report, Billy, the hackathons that are going on in GGC, of which all of the health and social care partnerships are taking part. And we have a culture hackathon next Friday, actually a week today, on the 5th of December. And that's just the beginning of a major push to look at culture and including families, patients, communities within that.
Thanks, Kath. That's a helpful reminder of the other work that's happening. I don't see other hands. That's been a really helpful discussion. I think it's teased out a number of things that are critical to actually the purpose of the IJB. So if I bring us to, we're on item 7 and there are recommendations, including items for approval. So we are noting the financial update, and we've spent a significant amount of time this morning going through the finances, but it is important that it's not finance for finance sake, it is what delivers our services, and I think that's really come across. We're seeking approval of the rephasing. We've spent a bit of time responding to questions on that, which were helpful this morning as well, and approval of the actions identified at section 5, and that includes some of the seeking out additional funding from partner organisations, as well as the activities set out that management are going to continue with. So all of those recommendations are set out in the paper at section 2 and the detail in sections 4, 5 and 6. We're content to approve those. Thank you. Thank you, everyone. That's been a really helpful discussion this morning. That takes us on to item 8, our annual performance management benchmarking report. Frances, with you on this one.
Thanks. This is a paper that we bring annually to benchmark our performance, principally against our family group, but also against the other 5 HSCPs within the GGC area and the Scottish average. Members will note it's a really detailed paper, so I'm just planning to pull out some of the key points, but we're happy to answer questions at the end on any of the specifics. So as mentioned, the focus of this paper is to benchmark the nationally recognised indicators, so that's the national core integration indicators and the health and wellbeing profile indicators against the family group. Now, the family group are authorities that are a similar size and profile to Renfrewshire, and that allows a sort of more meaningful look than maybe comparing us to some of the GGC HSCPs, which can have quite a different profile to ourselves. Overall, our performance compares positively. We've maintained our levels of performance that we reported last year, more or less against the family group and GGC, and we've actually improved our Scottish average for some of the indicators as well. There are several areas where Renfrewshire continues to be in the top 3 performing HSCPs among the family group. And this includes around unscheduled care, which members are aware of our already really strong performance in delayed discharge, which is evidenced once more. But we also have we've got 4 indicators in total that are in the top 3 relating to unscheduled care. In particular, I would draw attention to the number of days people aged 75 spend in hospital when ready to be discharged. And our performance there is really strong. We are 83.7% higher than the family group average, and it is over 70% higher than the GGC average. So a really significant performance there. Also, in terms of our health and wellbeing profile indicators in Renfrewshire, we've got 3 top performing indicators in the areas around child birth and child healthy weight and birth healthy weight, and around food insecurity. And that really aligns with a lot of the work and focus of our health improvement team and the partnership work we're doing with the council and GGC, and puts us in a good position given the priorities that are in the new population health framework. We've also, in the middle ranking indicators, where we're positioned between 4 and 6, we have still shown some signs of improvement within those. So small increase in the proportion of care services gradings from the Care Inspectorate that are good have increased from about 75% to over 82%. And I think that reflects the adult inspection reports that we've had through to the Audit Committee. Also, we've had a slight increase in the proportion of people that have spent the last 6 months at home or in a homely setting, and that's both against improved ranking against our family group and GGC. And I think that reflects the good work that we've seen coming through around our multidisciplinary home first response and other activities that we've brought to the meeting. The report also highlights in the paper areas of improvement that we continue to address, and we've outlined for these areas the targeted work against each of those indicators. Particularly, you'll note work around sort of general population health, and alcohol and drugs. So in summary, this paper presents a positive performance, and I think it's particularly notable given both the financial and resource challenges that we face, and we've talked at in this meeting this morning and in previous meetings. And I guess that members will be aware that from these updates, these pressures are likely to continue for the foreseeable future. So it will become increasingly hard to maintain this performance. The benchmarking of our performance, we use this as a core tool for part of our sort of continuous improvement cycle alongside the IJB performance scorecard. And I think it just provides really good, valuable intelligence for both baselining activity around sustainable futures, but also to inform the transformational work that we're looking to take forward. So that's just a very whistle-stop tour of a very detailed paper, but hopefully, while the benchmarking information's new, I think the performance shouldn't be a surprise to members, in the activity that we're doing it's been picked up in a number of other papers that have come to this meeting. Thanks.
Thank you, Frances. I'll go straight to questions. I've got Lisa Marie waiting.
Thank you, Chair. I've got a comment and a question. Firstly, really pleased to see that we remain at the top of the family group around readmission within 28 days and the number of days people aged 75 plus spend in hospital when they're ready to discharge. I think readmission particularly is one that, having worked in the social care sector, I saw there's a very clear pattern. If people are routinely being readmitted, they're not getting better and not managing to maintain their health. So that figure suggests that for the majority of people, they are managing to either maintain their health or indeed improve it with support of other services. So that's really positive. And in terms of prevention and further prevention, something we should always be aiming for. So really pleased to see that. I've got a wee question around the proportion of the last 6 months of life spent at home. We've got a bit of an improvement there. And we always work in percentages, and that's the right thing to do when you're mapping across a whole area. But there's a bit of me that likes the numbers behind that. So it's a smallish percentage increase, but I wondered if we know how many actual people that is. And I wouldn't expect that we would pick that out for every single element of the report, but I wondered if we could maybe pick out where there's a significance for the bits that are highlighted. If we don't know the number, I'm happy for somebody just to come back to me at a later date, but I think the kind of people behind the percentages is always really important.
Thanks, Lisa Marie. I don't have those numbers to hand right now, but I'll follow up, and it's a really important point actually for a number of the indicators, because when I was looking at some of the weight ones as well, it can sometimes be quite small numbers that actually move us from amber to green or vice versa. So in those situations, it would be good for us to add in the details. So I'll pick that up as an action, and I'll follow up with the one relating to end of life. Thanks.
Thanks, Frances. That's appreciated, and it's a really good report as always.
Thank you. Ian.
Yes, good report, good reading in it, and it's always good to compare ourselves with other local authorities. Just a couple of issues. The alcohol problem is still prevalent in this area, and it looms large, like a dark cloud over Renfrewshire, the impact of alcohol on our community. And I know there's a lot of really good work in various forums within the council, and I know there is a lot of hard work being done, but it is very difficult. And as we approach the festive period, we're probably already in a festive period for a lot of people, the issues with alcohol round about this time of year. It's something as a country we need to do better on. Delighted to see the emphasis on men's health and particularly mental health. And I know in Johnson there's just recently been at the opening of Andy's men's club, and we got a report earlier on in the week about that. So that's good to see. And I know as I get an older chap myself, I know for a lot of people they don't have a lot of family, you know, they might be divorced, they might be separated, their partner might have passed away. And for a lot of men, they're kind of floundering about in the dark, not really sure what to do with themselves. So all these initiatives are very, very welcome. The question I've got though is about falls. I see we're actually not performing all that great when it comes to that. Although again, there is seem to be a lot of work surrounding this. But my question is what can we learn from other local authorities, because they are obviously higher up the table than us, so they must be doing something better. So I just want to know if we are learning anything from practices that they have in their local authority areas. Thank you.
Pauline, would that be you coming in on falls at all? No. Right.
I suppose there's an inordinate amount of work that happens across the partnership around falls, and it involves a number of third sector as well as statutory services. I think Billy mentioned the falls promotion work that we've done quite recently in Falls Day in his Chief Officer report as well. So you can see in the performance report that we don't score very well in relation to the impact of falls. But I think across a number of services, Home First Response, the work that they do with ROAR, the rehab work and the work in social care as well around the prevention, identification of people that might be a risk for having a fall is dramatically increasing. So I would hope that we'll see some traction and we'll see some preventative work around that as we move forward. It's something that I don't believe is a quick fix. I think it's a long-term goal to try and improve that. And I think when you look left and right across all services involved with the population, you can see that work is absolutely happening, and we would expect to see some positive improvements at a population level.
Thanks for that, Pauline. Stuart wants to go in, but can I add to Ian's question, which is unfair given you've committed to answering now, Stuart? I guess Ian's question goes to the heart of more generally where there are areas where we're not performing so well. What is the process to seek out good practice elsewhere? And Falls is a good example of that. So that's an extra prong to that question, if that's okay. But Stuart, if you want to come back on the Falls piece.
I might dodge that latter part, if that's all right, and defer to colleagues. But I think this is linked to the prescribing question, and we know that polypharmacy and drugs are a cause of falls in older people and frail people. And actually, that's part of that process of reviewing and taking a realistic medicine approach. And certainly that is linked with cost savings. So I think that is another piece of work that is happening. The point I was going to raise really was just linked to the readmission rates and the number of days people 75 plus spend in hospital when they're fit to be discharged. I think that provides reassurance or assurance to the point that was raised earlier that actually if people were being discharged when they were not medically fit, or if that it was not an appropriate decision to discharge them, they would be being readmitted. But the fact we've got both the lowest rate of delayed discharge or people whose transfer of care is delayed and the lowest rate of readmission is really robust in saying actually that medical decision that these people are fit to be have their care transferred to the community, and that the care that they're being given in the community is also robust and provides that level of reassurance, I think, and is really good news. I'll defer about the less good news questions and how we learn.
Yeah, just I suppose around that point around sharing learning, I think that's a really important, for me, absolutely fundamental that all of our teams are engaged in that space. The hackathon was a good example of being able to do that across GGC. There are fora at the Scotland level. So, for instance, there was a conference that a number of us attended at the Beardmore a few weeks ago to share some of that learning. And I do know that having walked around and met with teams, that individual teams are making that contact with other organisations, and it's something that we'll continue to encourage. So, for instance, one of the networks, the Getting It Right for Everyone network, which is a national network, is something that we're re-engaging with. So I think a really important point and something that I'm really looking to promote and strengthen.
Thanks, Billy. Alan. Morning, Alan. Bring you in now.
Thanks, Margaret. I would just, it'd be remiss of me not to say on behalf of my colleague at Roar, Cassie, that the magical words of intervention, we've talked, intervention has been a magical word, so there's two. Early intervention in things like falls is obviously really important, and the cross-partnership work that Roar does, of course, with the authority and others, and the potential of One Wren's activities as well. To me, Cassie will tell you time and time again, it's about getting to people early and keeping them as fit as possible to avoid falls. And she's told me that enough that I know it verbatim, so I'm saying it out loud in the meeting. But I think that is one of the real important factors in this. There's a range of organisations about early intervention and well-being that can be having an effect on falls, and across obviously a myriad of health indicators. But I would, as I say, I would have taken a bit of a doon if I hadn't brought that up on behalf of Cassie. Thank you.
Right, and make sure that'll get picked up in the video and you can replay it if needed. Thanks, Alan. I don't see any other hands or questions in the room, so thank you for the benchmarking report, Francis, and we're noting the content and the appendix with the indicators. Thank you. That takes us to item 9, and it's the Chief Social Work Officer's report. So John, I'll hand to you.
Thanks, Chair. And appreciate the opportunity to speak to this report. I'll try not to speak for more than 40 minutes. No, people know that's a joke. It would be a first. I thought we needed to lighten it a wee bit. Listen, I'm delighted to present this. The report has already been considered by the council, but it is important, I think, that the IJB members get an opportunity to consider this report. The report's not a description of all of the activity of social work and social care staff across Renfrewshire, whether that be in adult services, children or justice services. But it is an attempt to show some of the depth and breadth and pick out some of the highlights of the reporting year. And it always feels a bit strange to be reporting about April 2025 when we're into almost December, but it's just the nature of the timing of the preparation and submission dates for that. Members of this board know that as Chief Social Work Officer, I have operational responsibilities for children and justice social work, but provides professional advice and guidance to Billy as Chief Officer, to the heads of service and to staff across the Health and Social Care Partnership. I do have some specific responsibilities in relation to adult protection and in relation to the operation of mental health services, particularly the mental health officers and guardianships. I'm eternally grateful, Mags, to the staff in the Health and Social Care Partnership who provide those particular services. They do it with rigour, they do it with compassion, but it is a challenge for them, and I work closely with them on that. The report, page 111 details some of the partnership and governance arrangements, and you'll see that my role within the HSCP and the IJB is highlighted there. I'm going to now take you a wee tour through the report. I'll start with children's services because it was in the beginning of the paper anyway, but actually whilst the children's social work are not delegated to the IJB, actually we work incredibly closely with the IJB or the health and social care staff around the protection of children, around the children who are looked after and accommodated, children who are looked after, but also that prevention agenda, and it's really important we highlight that. In the past 12 years, there was past 12 months, it feels like 12 years, I can tell you, there was a major redesign of our children's services delivery. And it was challenging. It was driven by a desire to improve the outcomes for those that we work with. And we wanted to create space for social work staff in children's world to spend more time directly working with the families that they support. We wanted to remove some of the administrative burden, but we also wanted to create a slightly different approach. And I'll highlight the change that we made to kinship carers. Kinship carers have often been treated as a second-class group of carers. and we looked at the support that foster carers receive from the team. There's a dedicated team of social workers who provide support to foster carers in terms of giving them support about the issues they face as carers. But in kinship care, the kinship carer and the child in that kinship placement had the same social worker. And there were occasions where there were conflicts there about the demands and needs. So we separated, and we now have a dedicated kinship carer support team. So that's social workers who work entirely and with the kinship carers, provide training support for their needs and not for the needs of the child. And that I think is a major improvement. I want to highlight just a wee bit of work in relation to the promise, because the promise, whilst many people think it's about care experienced children, it's about our general care experienced community. And what we do know is that for too many of our community who have care experience, the impact of care continues well into their adult life in a negative way. Some of the work in the promise in Renfrewshire, and there are significant commitments to that work from the Health and Social Care Partnership, is beginning to make a difference, and we are seeing improvements, but there's still a major route to go there. The promise report was published in 2020. We're now halfway through, and I think the pace is too slow, and we're going to have to increase that pace. And I'm hoping that with Health and Social Care Partnership colleagues, we will actually see improvement in the next 5 years. In justice world, I just want to highlight a wee bit, and I'll come back to the adult world, but I wanted to put the justice in just to get out of the way in terms of the flow. You'll notice I called it justice and not criminal justice. That was a deliberate change in our strategy in the past 12 months. We recognised that the use of the term criminal was labelling for those individuals who are in conflict with the law. Those individuals are often parents, their brothers, their sisters, their aunties, their uncles, their cousins. They are workers, they are people with disabilities, they are people with challenges, they are people with talents. And calling them criminal limited the opportunities, I believe, for rehabilitation. So we dropped that deliberately. And you'll see that we are, I think, now seeing a different approach across the service. The report on pages 119 to 121 details the work around adult social work and care this year. And I made a deliberate decision to focus on the issue of working to protect vulnerable adults. Not because the other work is not valuable, but actually we do spend a lot of time, I think, in IJB and in other fora talking about the care at home service, about the residential care service, about learning disability services on a day basis. We don't often talk about the protection of those most vulnerable people in our society. So I wanted to do a bit more in this year's report to talk about that, and to give you as IJB members, but also elected members back in the council, an assurance about the quality of the work in Renfrewshire. The work in Renfrewshire to protect vulnerable adults is good. In fact, it's better than good. It's very good. It's high quality, but it remains incredibly challenging. And I just wanted to put that in. The other bit I want to put in is that work doesn't happen in isolation. It's not only social work staff, it's staff across the whole partnership, whether those be health professionals, social work professionals, or social care professionals, but also working with families. It doesn't happen in isolation, so I wanted to get that across. I'll skip over the bits about the regulation because it's covered elsewhere. Workforce remains an incredibly challenging area. The Health and Social Care Partnership, a bit like the council, is seen as an attractive employer across Scotland. It doesn't mean that we manage to recruit to every vacant post that we have, or we have all the skills that we require, but actually we are an attractive place to work. And that's because there's a real commitment to support staff in doing that. I'm going to take us on to budgets now. I'm not going to get into too much detail about budgets because there's been plenty of work, but I'm going to make a comment, and I did make it at council, and I could see a few folk at council probably being a bit uncomfortable when I made the comment, but it's important that I do make it. Every year, officers in the Health and Social Care Partnership are asked to consider saving options around financial pressures. And that becomes incredibly difficult for IJB members who have to vote on those options. However, I wanted to say that when those options are presented by the staff, and this includes our health colleagues, so I'm taking a wee bit of liberty, Chair, to drift in there. When those options are presented, I know that they present a real challenge to IJB members because they're really uncomfortable, but they're made from a starting point where the professional officers actually consider all of the options and only bring options here that are well considered, that are ethical, that are based on helping you as IJB members make difficult decisions. They are often the worst, least bad decisions. So, you know, the least worst decisions, you know, none of the decisions or recommendations are ones that we want to make, but they're made with integrity, they're made with honesty, and they're made with professionalism. I think on occasion we do get caught where some of those options actually are about transformation and improvement, but will still save money. But because they are tied in the financial package, we get that lost. And that could, and I would put out one of those areas, particularly is around how we structure our learning disability day services. There are real opportunities there which would provide better opportunities than our current service, but because it's tied into finance, it gets lost. So I'd want us to think about that as we move forward in the next stage of our sustainability programme. I'm going to finish just with a thanks to Billy and his team for the support they give to me and the allowance they give to me to come into the health and social care world and challenge the decisions they make, but also support them. And then I just want to say that today and every day of the year, we have staff in Renfrewshire who are on the ground, who are delivering care in people's homes, in our residential services, in our day services. And actually, they actually are what this is about in terms of, because if we don't have them delivering the care, then the individuals that we are required to support will not have the quality of life that they should have. So without our staff, the quality of life for individuals in Renfrewshire will be poorer. So please remember that and allow me to just close by saying thank you to all of those staff, whether they be care staff, social work staff or health staff in this partnership. They do a tremendous job. Thank you, Chair.
Happy to actually deliver the service. Thank you. Lisa Marie, come to you.
Sorry, all my teams is a wee bit slow this morning. Thank you, Chair. It's a comment rather than a question again, because as John says, he's presented this at Council already, so I've asked him my questions and feel quite content. Firstly, I want to reiterate what John said about the staff. The teams that he oversees and that are detailed in this report, the work they do is often with people in the most difficult of circumstances, or people going through real transition points in their life where the intervention of staff can make a really significant difference towards a positive destination. And I think that's something that we should never overlook. So thanks to them, but also thanks to the families and people that we support for engaging with those staff members at those tricky times. It's often people who have been involved in services for a very long time, and people do get a bit of service fatigue, and the fact that people continue to engage and try to work towards a better life for themselves, I think, is to their credit. I just wanted to comment briefly on a couple of things. The report was excellent, as always, John. Gives a real view of the breadth and depth of work that we do. And I say breadth and depth because you can do things to a wide spectrum or some things to depth, but to be able to do all of this work to breadth and depth is really significant. So I just want to note that. And I particularly wanted to comment on the work around the promise and your reference to it being about adults, because it is. We have people for whom their care experience echoes throughout their entire lives. It doesn't stop when they're 25. It's positive that we're now in a place where we have a transition phase for younger people, where we have that 18 to 25 aspect, if that's what they wish. But there are people who we support who, when the promise was conceived, were already adults who'd experienced quite significant trauma from that, I think, in their life, and some of those people are the people you will work with in justice or who are engaging with other services, and the fact that that's reflected across the piece is really important, I think. And I also welcome the removement of the criminal to justice. I think that when the courts or services have decided that, you know, things like doing work in the community things is the way to go to people, then we should take that as us being told that these people are being given a chance to change their life positively, and we should support that. So I really welcome that. I think the language we use can stigmatise people or mean positivity for them, and I think changes like this are very good. And that's all I have to say.
Thank you, Lisa Marie. I've got a couple of hands up in the room. I'll come to Linda first. Thank you, Linda. Then Kath.
I just want to say, first of all, thank you for recognising that care experience does go into adulthood, because I'm care experienced myself, and it does not end at 25. There's no cure that happens at 25, so I want to thank you for that. Also, just a couple of questions. Just how do you see care experienced people informing their care, and how would you involve them in the care and decisions that have been made about them with their education? And how are you tackling stigma in communities and schools? And my last question is how the Chief Social Work Officer ensure that protection processes remain transparent and trauma informed within this process? And again, how are you supporting the social workers? Thank you.
Wow, Linda, that's a question, isn't it? But actually a phenomenal question. So I really do welcome it. And I think that, you know, the first thing we need to look at is that we didn't all just get here today. There have been many, many years of trauma, of poor practice that was probably considered to be okay at the time, but we recognise now with the benefit of hindsight isn't. So we have a number of different structures to speak to care experienced young people who are currently in the system. We have a group that, in fact, just last Thursday, a week ago yesterday, celebrated a 10-year anniversary of the Breakthrough Group, a group of children and young people who are in foster care, who inform how we work, both challenging the foster carers, challenging the social work department, and they decided to celebrate by having a masquerade ball, which actually was an incredible piece of celebration, and really, really quite a joyous celebration, but also told us some hard messages. So we listened to them. We have a Promise Network. We used to call it the Promise Champions. We just call it the Promise Network. Those are care experienced young people who reach into adulthood, as well as children who are still currently in the care system. And again, they provide that feedback. We speak broadly to the Promise team at government. We speak to the Promise team led by Fraser McKinley, and we hear from that. We are currently looking at how do we speak to those adults with care experience who are still involved in our systems, whether it be through health, whether it be through the child protection, because unfortunately too many parents of children today have care experience, and that experience has resulted in them having to be presented to the child protection world. So we are looking at that. So that's maybe something I'll come back to yourself on in terms of looking at how we develop that. Within our schools, we've had a number of programmes. We worked very closely with Who Cares Scotland. They developed a programme called Communities That Care. It was an in-school programme that was based on challenge and stigma. So we celebrate and that we normalise care within our schools, so that hopefully it loses the stigma, so that people don't think, and unfortunately too many people still think being in care means that you've done something wrong. And the school programme was about challenging that. It was about celebrating success. So we do that. And I think the wider world, one of the things that we do mention is our Promise Keeper network. And in Renfrewshire, unlike many councils, when the Promise was established, the report was published, the chief executive, the directors, the heads of service, all those folk who think they're really important said, oh, I'm a Promise Keeper, I'm in charge of the Promise, I'll deliver the Promise. In Renfrewshire, we listened to our care experience community who said, actually, you can only become a Promise Keeper if you're making an absolute commitment to do something different. And therefore, we set up a selection process. You need to apply. You need to say what your promised change will be, and it's led from the ground. So we've got almost 400 promise keepers across Renfrewshire who are employees, and they're in the Health and Social Care Partnership, they're in the council, they're in the third sector, they're in the police, and those individuals are shaping practice and changing practice, because actually, much as I'm very proud being a social worker, it's a long time since I've had to chap a door or do that. So we need to have that on the ground, and we've got a tremendous network. It includes elected members, as I say, and there is an invite. If anybody wants further information about the Promise Keeper network, let me know and we'll get that to you, and we'd invite more folk to join. So thank you, Linda. Brilliant questions.
Linda. Thanks, Chair. Thanks, John. Excellent report, and the way that you have highlighted throughout that wider societal context that we're facing in terms of widening inequalities and poverty issues. I just wanted to thank you for how you framed the challenge that we face as an IJB and partner organisations in navigating those value tensions that you described, and navigating that together for those different solutions. And I thought your example of learning disability was particularly vivid, in that redesign isn't always loss. It is actually potentially transformational to the individuals that are in that context. So thank you. Thanks, Kath. And thanks for the report, John, and the discussion that followed from it. I think that was really valuable. Where the recommendations at section 2 are to note and acknowledge the detail of that. So I'll take those as agreed, and the discussion that we've had around that. So thank you very much. That takes us to item 10 in the agenda, and back with you, Frances, is that right? Thank you.
Yeah, thank you. I'm really pleased to present Renfrewshire's Local Child Poverty Action Report for 24-25. Some members may already be familiar with this report when it went to Renfrewshire Council and also the NHS GJC Population Health and Wellbeing Committee for approval. This is a statutory report that every local authority and its health board must publish, and the report should set out what's been done to reduce child poverty and improve outcomes for those children living in poverty over the last year, and also what's planned for the year ahead. We've structured the report around the Scottish Government's Best Start Bright Futures delivery plan. It's 3 themes, which are supporting parents into work, maximising family incomes, and helping the next generation to thrive. For me, one of the really positive things I'd highlight in this report is the key role that the HSCP has played in leading and coordinating local action. And I think that is something that's shining through the report that we've maybe not seen in previous years. And I think it does reflect the more collaborative approach both the HSCP and our wider partners, not just the partner organisations, but third sector and communities are working together to try and have a more joined up response, particularly in relation to cost of living pressures and tackling inequalities. So in the cover report, we've tried to pull out some of those sort of HSCP examples where we feel we're shaping those priorities. We've coordinated the delivery, and I suppose importantly embedded a sort of public health approach that focuses on prevention and early intervention. I think central to this approach, and certainly how we want to take our more transformational work forward, is embedding living experience, empowering communities, and working really closely with the third sector to ensure that we're designing the services around what matters most to families and people living in our communities. I don't plan to go through all the examples, and I think some of you will be aware of some of this work from our annual performance report and other reports, but I hope it gives you a sense of the impact that we're making through initiatives such as Stronger Start, and the HSCP chaired the steering group for that, working with the Citizens Advice Bureau, so another partnership piece of work to support women engaging with our Blossom maternity service, both in Renfrewshire, Inverclyde and Western Bartonshire, and it's providing a whole host of support for people, from money advice, advocacy, and just preventing homelessness as well. And the approach that we're using was informed by women that are facing social vulnerabilities and their lived experience, and the wraparound support that they feel that they need. So it's only been in its first year, and we got 135 referrals, and we also saw that the families that engaged with that service, we totaled £150,000 extra sort of income to those families. Also, just highlight other initiatives like Thrive Under 5 that we've worked with active communities, and also with the Renfrewshire CAB, and that's supporting young families and children, really practical support and help around meal packs, pantry vouchers, cooking equipment, but a real focus on sustainability, giving people skills that they can go on and use going forward. And then finally, I would flag the Gala Hill work that we've been doing. And the work that we're doing in Gala Hill will have far-reaching, I suppose, consequences. But we did start this work because Gala Hill had some of the highest levels of child poverty, deprivation. But actually, as we've done a sort of deeper dive, spoken to the communities, there's a lot of wider health inequalities and challenges facing that community. But I think it's a really good piece of work, not just for the people of Gala Hill, and we've got to do it justice going forward. But I think the approach we took, that place-based approach and working with the community, with the third sector, gives us a template that we can take forward and use elsewhere. So I'm looking forward to sharing more information about this work at future meetings, and it's been driven forward through the community planning partnership. The HSCP led on the community needs assessment, working with active communities, but going forward, the council are going to become the lead for the next phase of implementation. And once that goes through the community planning partnership, we'll look to share the details of what that looks like. But I think that could inform a lot of future work that we're involved in around health inequalities. So hopefully some of these examples just show the scale and depth of the HSCP's contribution. One risk, and it's been a recurring theme today, is just around the sustainability of some of these. And you'll appreciate that quite a number of these programmes rely on short-term funding. So that is something that we're very thoughtful on about, and a real focus within our health improvement team, and I guess just as an HSCP generally, is that we're looking at how do we evaluate, create the evidence of the impact of prevention and early intervention, because that can be more challenging and subjective than some of the clinical improvement work, but it's central to the work that we need to take forward, and to also deliver on the population health framework. So overall, I think a really positive report, but just some thoughts about that future sustainability and that shift in the balance of care to allow us to do more of this work going forward. Thank you.
Thank you, Frances. I think you've touched on a number of things that we talk about a lot as a partnership and within the IJB around community planning partnerships and greater involvement, and actually joined up in that thinking to have greatest impact. So I think this work is really important. Ian, I'll bring you in.
Yeah, a very good report. I certainly enjoyed reading through it. And I think both governments, UK and Scottish governments, have put child poverty right to the top of their agenda. I know John Swinney, just as recently as yesterday, was mentioning it in Holyrood to say that was his government's priority, and I find no disagreement with me on that one. And obviously the 2 children gap was lifted the other day by the government down in London, and I think that's to be welcomed as well. That's also all about putting money in people's pockets, and at the end of the day, that's how you end poverty, is by giving people money or encouraging them to earn more money. that's a fundamental thing for me. It sounds dead easy to do. I know it's not. Certainly, when I looked at the rates of poverty in child poverty in Renfrewshire, quite startling the differences between Paisley North West and the likes of Bridgevere. They're probably only, I don't know, maybe 4 or 5 miles apart, but there is well being a world apart. Some of the differences that we have here in Renfrewshire. I was interested to see the average wage of people in Renfrewshire is £745 a week. For a lot of people, that's just totally unimaginable, earning that amount of money. We've also seen the other day the minimum wage going up as well, which I think is to be a good thing. I know some employers are not too happy about that, but I would say I would fully support that. What I found very interesting, and maybe I'm just giving away my job centre background here, was about the local employability. I think there's a lot of good work on in there. And referring back to my earlier comment, just we need more people back in work. I think there's something like 17% of our households don't have anybody working, and that's far too high. Now I know there's reasons for that, and I know that people have health issues and sometimes confidence issues about entering the workplace. So I know it's not always dead easy, but we need to really work as hard as we can through all our partners, the council, the job centre, Skills Development Scotland, and everybody else that's involved. And I think education has to play a major role in this as well. I think there's too many of our kids lack a bit of aspiration for a variety of reasons, and sometimes they don't think they're good enough to do things. And I think our education system has to make sure that every children has something about them, has something to offer the community, and that job, being in work is a good thing, and it can certainly open up so many doors and opportunity for you. So as I say, we don't have a problems to seek when it comes to poverty here, child poverty here in Renfrewshire, but I'm heartened by the amount of work that's going on both here in Renfrewshire and in Scottish and the UK governments. But we need to keep working as hard as we can to try and minimise this. We'll never get rid of poverty, and people talk about getting rid of this and rid of that. You'll never get rid of it all completely, but we can do our best to minimise it. Thank you.
I was almost content not to offer this appreciation until you said what you said at the end, and I thought, oh no, that matters. I think that growing up in poverty is difficult. Living in poverty is difficult. I continue to find new things that make me go, oh, that's sad. We never had that choice growing up. Or, oh, that was an opportunity that I didn't know people could get if they had money and wealth. And that continues to go around. And I think thinking about the idea that the answer to poverty is people having more money, I agree with that. I think the opposite of poverty is not just wealth, though. I think there's a justice component to that for people. The thing that I appreciated largely in this report was the attempts and projects that seek to offer people joy and excitement and fun in their life. I don't resonate with depictions of kind of Ken Loach films of everybody who doesn't have money just being miserable and everything about their life being kind of diabolical. That is the reality for some people, but I think that one of the things that this report pulled out is that there's evidently clear attempts not to just simply address the fact that poverty is bad and people need money and projects to get more money in their pocket and help with heating. Those are all really important, but those are well trodden. I feel that's why I don't have to comment too much on those. But actually what you said at the end made me think that as we seek to address poverty, we can cleave towards those things that are about kind of like income maximisation, making sure people have food, making sure people have enough in their meter for their heating and stuff. That's all really valuable. So too are those things that make people's lives a bit more bearable and a bit more enjoyable and present opportunities for people to transcend their experiences and to take the next step, whether that's a music project or a cooking project or so on. So I think it's an appreciation that that's in the report, but I think it's also just a kind of marking of like, that would be a shame, I think, if when things start to be considered, we cleave towards the things that feel more practical and not necessarily those things that may on the surface, if they're not statutory, not seem that important, but actually I feel like are quite critical in this report.
the room as you're making those comments. So but really valuable to raise those points, because I think we can all understand that joy isn't just about, you know, you do need heating on, it doesn't bring you joy. That's just a basic. So thank you for that. Lisa Marie, I've got your hand up next.
Yeah, thank you, Chair. And I won't belabour the point too much because I think Jamie spoke really well about it. But as I said earlier, I am the chair of One Ren, and you know, I think that thing around it's not just about wealth in your pocket. It's about richness of experience and opportunities. And I think Jamie spoke about that really well in this report, highlights that really well, and we're of course partners in that. But I think we should be looking at every opportunity we possibly can for that, because those opportunities, they give people the joy, they give people that richness of life, but they also broaden people's perspectives and allow them to maybe reach for things they wouldn't before. Ian talked about people wanting to work, people maybe, you know, children feeling more confident, people feeling more ambitious, and as well as bringing joy, which is important in itself, and richness, these things also support people through that. I really, like, I am a person who grew up in a mining village just after our pit closed. Everyone I knew would be considered to have been in poverty. But, you know, access to libraries, being able to do art classes, being able to go to museums for free, and someone supporting families to be able to do that. If you live in somewhere that's a bit more off the beaten track, these things make such a difference. So I really resonated with what Jamie said there, and I think it should be a key part of our ambition.
Thanks, Lisa Marie. Likewise, lots of nods in the room. So, Francis, I think you appreciate that report was very well received by members this morning. We're noting the detail of it. There's no particular action for us as an IGB, but certainly support the direction of travel and look forward to getting updates, in particular around that, working together going forward. Thank you for that. So, next item 11, is the winter plan. Winter is certainly here. David, over to you to take us through this.
Yeah, thank you. So this report asks the IGB to note the winter plan that's been developed by the HSCP this year, with the update that we've provided really following a similar structure to last year's paper. The national context for our winter planning has been set through the Scottish Government's surge and winter preparedness guidance, which is now intended to cover local responses to surges in demand throughout the year and not just in the winter period. I think the detail on that is really quite similar to the approach that we've adopted in Renfrewshire over recent years through our wider business continuity work, and which we've also outlined in this report as well. At that national level, there's 3 key priorities which have been set out, which are to ensure person-centred and person-led care, to work in partnership, and to implement local and national actions which we know work. And these are also supported by 5 principles which align closely with the IGB strategic plan. And I think also around a lot of the discussion that we've had this morning, with a focus on prevention, providing care at the right time and in the right place, and also supporting patient flow through the acute system. And underpinning all of these is the need for us to continue to support the mental health and wellbeing of our staff, and also for us to support unpaid carers as well. As we also do each year, we've reviewed the existing and emerging winter risks. And again, these remain broadly similar. However, I would note in relation to the risk of an increase in winter viruses, I think members will recognise that we have seen an earlier spike in the flu and an earlier start to the flu season, which is being driven by a different strain this year. And we know that this has the potential to put strain on services and on our workforce over coming months, and we'll continue to monitor that closely. The risks also identify that this year, as was the case last year, the HSCP is managing its winter response within existing resources, and that's within that ongoing financial context that we've talked about at length already this morning. Whilst we've been developing the winter plan, we have liaised closely with NHS GGC and with Renfrewshire Council to develop it, and the actions that we've been taking with them are set out in sections 7 and 8 of the paper. One example of this work, which Billy mentioned earlier, is the work we're doing to participate in GGC's system reset activity, which is aiming to maximise safe admission avoidance and also enables timely discharges in advance of the winter period, with the aim of freeing up capacity in our hospitals. And we've also been working closely with council colleagues, and we tested our planning with CMT recently, and that was really well received as well. Appendix 1 itself sets out the summary of actions that we're taking, which are structured around our winter planning scenarios. And that captures the actions that we're taking at our individual service level, but also the cross-cutting actions that support all of our services across the HSCP and more broadly. I'll not go into the detail of these. However, I would note that our winter plan will remain a live document and will be monitored by SMT over coming months. And we'll also bring a wider update on business continuity activity to the Audit, Risk and Scrutiny Committee at its next meeting in March 2026. But very happy to take any questions.
Thank you, David. Certainly, as Health Board members, we see similar updates in terms of wider winter planning. So I don't see hands up there. Ian, bring you in.
Yeah, again, good report, lots of good stuff in place for planning. So it's one thing you can never predict is what kind of weather we're going to get. It was bizarre. Yesterday it was like 12, 13 degrees, and you're saying, it's nearly Christmas and it's 13 degrees. Seen some of the kids in my area going to school in their shorts. You're like, what's going on? But we know just last week it was like -1, -2. So it's a bit bizarre. Our weather's all over the place. And when I was looking through previous papers, I remember the last year's IGB in January being cancelled because of the mad storm we had in the Thursday night. So we know that this disruptive weather it can just be around the corner. So it's obviously good to have plans in place. The question I was going to ask was about uptake of the flu jab. Now, I used to qualify for my flu jab. I no longer qualify for my flu jab, but I managed to get it. I'll tell you how, but I managed to get it. But I just wonder if a lot of people are almost fed up of JAGs. There will be people who are enlightened and understand the need to get a JAG. It protects themselves, it protects others, makes sure they're well enough to look after, kids or older relatives. So there is obviously, I would like to think, a good uptake amongst people. But certainly people I speak to, I can't be bothered. What's the difference? It doesn't make any difference to me and all this kind of stuff. So I just really want to make sure there's still an uptake of the people who are actually qualifying for it. And is there any evidence of people doing it themselves, people like myself who probably wouldn't normally qualify for it, getting it done privately? Because I know a few friends of mine say, oh, I really need to get it. I don't qualify, but I'm prepared to go to Boots or whoever else to get my flu jab. And of course, related to that, I suppose, is a COVID jab. I'm just to say, I would like to be interested. I'm interested to know what the uptake on that is as well, if you've got that information. Thank you.
Thanks, Ian. I'm going to pass over to Pauline Robbie just to pick up those questions.
Thanks, Councillor McMillan. I'll have some of the information, but perhaps not all, so we can come back later. Certainly from a population level across GGNC, there's the board mass flu vaccination and COVID vaccination for those people eligible. And certainly for COVID this year, the guidance meant that some people were not eligible for both COVID and flu. And they pick up the figures. I'll need to come back to you with the kind of wider figures around that. But certainly locally, the messaging for our staff in particular is really clear, and the opportunities for people to get the flu vaccine, because it is only flu that staff are in scope for this year, is really strong. And we're making that opportunistic achievement of getting your vaccine if you choose to decide to have that as easy as possible. NHS staff can attend any pharmacies, but we're also going around team buildings as well, and that's all publicised within all our networks and our communication programme. From our highly vulnerable population, our housebound population, and those people that are in care homes that are eligible for both COVID and flu vaccines. The care homes have been finished. We started that at the beginning of October when the programme started, and it was finished by the end of October, albeit you'll appreciate that the population does change and we have new admissions, so we do have catch-ups to do, which we'll pick up this month. The housebound population of those patients that are more vulnerable and can't leave the house and their carers is ongoing just now, and we're almost at the end of that. We predict we'll be finished that by the end of next week, and then we'll have, again, people become housebound, so we'll have some catch-ups to do, and for those people that might be in hospital. So that's well underway. What I would say, and I think you're right on the money, there is vaccination fatigue. So the messaging has been really, really clear around the benefits, both from your personal benefits, the benefits to your family, and the benefits for our patients are really well documented. Our managers and our public health messaging is really clear about why people should consider that. But again, it's not mandatory. We just need to make sure we keep driving that message home. And certainly, Renfrewshire wide, about 26% of our health staff, but only 9% of our social care staff have taken on that opportunity to be vaccinated at this point. So comms team's been working quite hard with service managers just to make sure people know what's available, how to access, and when we're going to be in their own building, if that makes things easier for them. So I hope that answers, and I can come back with some of the wider stats later.
Chair, can I just have a follow-up question on the vaccinations? There's a few people have contacted me. They got their appointment through to get their JAG, and they lived in Johnston. Now, they were allocated Renfrew to get their JAG. Now, I know of one particular person who lives basically across from the town hall, my dad. He got an appointment in Renfrew. He's an 84-year-old man. Now, that would have involved him getting 4 buses to go to Renfrew, because he doesn't want a lift off me. So he's like, I'm not getting 4 buses to go to Renfrew. So being the person he is, he managed to get an appointment in Johnson. But there've all been people who have just been like, oh, I need to go to Renfrew. And from some parts of Johnson, that's 6 buses to get to Renfrew. So I wonder what the methodology is when selecting people to go to certain areas. For people in Johnson, the obvious place is Johnson Town Hall, because at the very, very worst, you need 1 bus, or for a lot of the population in Johnson, they could walk it. But to get asked to go from, say, the back of Johnson Castle or Spatson to Renfrew, and if you don't have access to a car, or you don't have a family person, a family member that can take you, it's quite an arduous journey. And you could be put off and say, oh, I'm not going to bother, I'm not going to get 6 buses just to get a JAG, I'll be fine. So I'd just really like to know how that gets selected. Thanks.
Can we not pick up specifically Ian's dad's position on this, just more generally, because it is across the board, Pauline? Thank you.
Yeah, I mean, you'll appreciate that we won't be organising that. That's a very central process that's done. But I can come back to you with the process. I'll double check. And I agree with you around the practicalities for people. I know that they can change, but again, I appreciate that might be quite challenging for some individuals to make that change of appointment. So if I could come back to you with exactly how that works, I'll need to go to the central team. Thank you.
Kath, is your point on vaccinations, or I'll take Alan first. His hand is up here. Alan, come to you first, then Kath.
Thanks, Max. It's really just my ongoing work on sharing information like this to, obviously, particularly, I'm thinking selfishly, third sector partners. If there's any sort of updates and sort of ways to make sure people know that there's plenty of winter planning going on, where services might be affected, etc., just to make sure that's shared as wide as possible. Billy's been doing a vlog that we've been sharing, and actually people have been picking up on that. So that sort of thing is really useful, just in terms of helping people understand that this is something that the Health and Social Care Partnership are really heavily up for and do a lot of work behind. I think there's some great news stories here in relation to carers, etc. So it's my ongoing plea of sharing and actually giving a bit of profile to the work that happens, so people actually feel the benefit of that. Even if they don't engage with the services, they recognise the Health and Social Care are on it. Thank you.
Thanks, Alan. That's a really helpful point to make. Can we pick that up specifically if we're not already capturing? I'm getting nods from Francis and David on that. Thank you. Thanks, Alan. Kath, bring you in now.
Thanks, Chair. David, I'm sensing from this report that we're in a stronger position in terms of preparedness than perhaps I've seen in the past, and noting the whole system approach. And obviously I've seen the paper when it went to NHS GGC board in October. It's a live document. Will this come back to IJB? Will we get regular updates in progress of any changes or attention to areas that perhaps where performance isn't quite as we'd hoped?
Yes, we're certainly happy to share any updates as the plan progresses. I think, as I mentioned, we'll bring a fuller update to the Audit, Risk and Scrutiny Committee in March, considering all of the business continuity elements on that. We did do that in March of this year, but I think you are right in terms of our preparedness for winter. We are in a strong position. I think it's been a process over a number of years in terms of developing our plans and the approach that we take. That means actually this year and in recent years, it's not been about a wholesale development of a new plan. It's about building on what we've done previously and learning the lessons from previous experience. So we kind of talked about the weather last year and Storm Eowyn, and it's about learning the lessons from that and just building that into our plans, but certainly happy to provide any updates as they come through.
Thanks, David, that's helpful. So we're noting the winter plan update that with the actions in place there. Thank you for that. That takes us to the final item. It follows on actually from David's comments. It's the update from Chair of Audit, Risk and Scrutiny. So I'll hand over to Lisa Marie for an update of your previous meeting, which I believe was just last week.
That was, thanks, Chair. Does it feel weird that you're not doing this? Okay, so firstly, I just want to note that we welcome Jamie and Kath to the committee and that several members undertook SIPFA's Introduction to Knowledge and Skills of the Audit Committee training last week, so we are freshly up to date with what we should be doing. We looked at a number of regular items, all important, but I'll pick out a few that are key for the IJB as a whole to be aware of. We approved the internal audit charter and mandate. This was last updated in 2023. It was noted that this version is more detailed and robust, outlining the role of internal audit more fully than in the previous version, and also taking into account recent updates and guidance. As always, we had an update on the risk and issue register. There are no significant changes in the version from the last approved version, though of course we still maintain several items of very high risk. Members reflected that our upcoming development session will be considering the risk appetite of the board across our remits, which is important given the recent changes to membership. And the last one that I'll highlight is that we had reports from the Mental Welfare Commission visits to North, East and South wards at Dyke Bar. There were lots of positives across the 3 wards reflected by members, as well as a number of actions. All of the actions are subject to action plans, as always, the completion of which will be reported back, and many of the actions are already underway, with some positive changes made by the time of the meeting. We were particularly pleased to note that many of the positives were around good relationships with patients and family, and around a high standard of care, things that I think we would all be looking for, and I have nothing other than that.
Thanks, Lisa Marie, that's helpful. Don't see any questions for you, so we'll just note that update. Thank you. So that just leaves me with confirming the next meeting of the IJB will be on the 30th of January, again hybrid here and online, here being the council chamber and online. And just, I guess we have a development session. I know we've run over a bit this morning, but I was conscious the quality of conversation was really rich, so I didn't really want to stem any of the discussion. So I hope everyone's diaries are able to accommodate that. We'll have a short break and then members can join, if you are online, on the separate link. I'm looking around just for a timing of when you want us to join on the separate link. 1:45, just a quick 7-minute gap to comfort break, and then we'll join on the separate link. Thank you.
Thanks, Chair.